So a warm welcome to everybody joining us for the third session on the first opening day of our this three-day event that we've put together with our partners and stakeholders from across the world. Thank you very much to the organizers and the people behind the platform, the ADVA support team as well for this. Welcome to everybody joining us from across the world. This particular session is going to look at dengue, biomarkers, pathogenesis, and establish new horizons for potential dengue therapeutics and diagnostics. What's been really evident in the previous sessions that we've seen is the massive complexity when it comes to the immune landscape post-bite. So really we're talking about the kind of the way that immune landscape is informing treatment strategies, clinical management, as well as opening windows for potential new drug targets, earlier biomarkers for better diagnostics, and certainly the need for those has been emphasized by the previous speakers, Professor Tiki Pangestu's session in particular, as well as Professor Rosario's session to kick the things off in the morning. So I think the need is definitely there, and certainly COVID has really highlighted this whole COVID situation, the need for more diverse approach to the way we look and get a feel for the mechanistic understanding behind infectious disease, and especially within dengue, this is true. The underlying mechanistic causes in terms of the dominant clinical features of severe dengue, and by that really I'm referring to the transient increase in terms of vascular permeability, really the vascular leakage, they remain to be better understood. And really the principle behind that, developing better understanding of that pathogenic, the landscape as it were, is that those deeper insights will give us improved treatment strategies, and it will obviously uncover, as we said, novel drug targets that are needed outside of the vaccine world, and also give earlier biomarkers that could be used for those diagnostics that are in urgent need. So I think leading the charge in many ways in terms of this particular research field are three of our panelists that we've the honor and pleasure of welcoming to this session. The first of those speakers is going to be Dr. Prof Neelika Malavige from the University of Colombo in Sri Lanka, working closely with the Sri Lankan Ministry of Health, as well as collaborations with Oxford University as well. I think that's kind of more than enough. I think for me, I think we're kind of wary of the time. What I would ask is that there will be a Q&A at the end of the session. We're being joined by lots. We've had over 2,000 registrations in total in terms of the 3 days. I know we've got quite a few people here for this particular session. What I would say is please feel free to put your questions forward. I will try my utmost to channel those into the Q&A at the end. And if you could add your name, your country, and your affiliation to that question, it would make it easier in terms of a point of reference. That would be the only kind of housekeeping rule that I'm going to mention. I think that's enough from me, and I think it's time to hand over the floor to Dr. Prof Neelika Malavige. So Neelika, over to you.
So welcome to this session on the pathogenesis and biomarkers. I'm from the University of Sri Jayawardena, Sri Lanka, and I'll try to talk a bit about the pathogenesis and biomarkers of dengue. And I don't think it's, I should be talking about the global burden of dengue in this forum, of course, given that this is for the World Dengue Day. But we know that about 390 million infections of dengue occur annually. And the important things I would want to highlight here is the disability and the mortality. So dengue is seen in the tropical and subtropical areas as shown in this map, and the Southeast Asian region and the Latin American region are heavily affected by dengue with very high numbers of case loads. But when it comes to mortality, for some reason, the mortality rates are higher in the Southeast Asian and South Asian region compared to the Latin American region, despite high caseload in both areas. And that is something we need to look into why we get this difference. And apart from mortality rates, the burden of dengue, the disability caused by dengue is again more in the South Asian and Southeast Asian region compared to the Latin American region. Given that so many people are infected by dengue and it results in such a massive burden in especially resource-poor countries, dengue was named as one of the top threats to global health by the WHO in 2019. Now, I come from Sri Lanka, and we've had dengue epidemics annually, biannually since 1989, except for 2020 for some reason, with the emergence of COVID and maybe the restrictions, social distancing, and other measures taken. 2020 was a very quiet year for dengue. But as you can see, in Sri Lanka, if you take from 2006 to 2017, dengue has increased, the number of cases have increased along with wider geographical spread. And in Sri Lanka, the number of cases, the proportion of rising cases has been especially higher in old individuals compared to young individuals, the mortality and the morbidity. And of course, we don't know why this change in this age pattern is there, but the morbidity and mortality rates are highest in individuals between 20 to 40 years of age, and proportionately, the caseload is lower in school-going children compared to adults. And things have not been good over the years, and especially in 2017, we saw a really large dengue epidemic caused by the dengue 2 virus. And Sri Lanka is a developing country, so it is usual for our hospitals to always be full. And in dengue seasons, we have 2 patients per bed and 4 patients. But in 2017, because there was such a large number of patients, for the first time in Sri Lankan history, we had patients in corridors. So that's how bad it was in 2017, much worse than the COVID situation. Now, as previous speakers in previous sessions have mentioned, the vast majority of dengue infections are asymptomatic, and which is most important. People don't show symptoms, they don't know whether they're infected. Some people do develop fever or symptoms, but those are not reported as dengue fever because those are not very severe. People don't come for testing or they go unnoticed. Another proportion of patients do develop dengue fever, and a minority develop complications of dengue in the form of dengue hemorrhagic fever and dengue shock syndrome. And then the WHO has categorized another clinical feature, which is expanded syndrome of dengue infection. So this is organ dysfunction in the absence of vascular leak or dengue hemorrhagic fever. Now, how do patients with dengue present? They present with fever, lethargy, muscle pains, joint pains, headache. Sore throat is sometimes seen in children, a large proportion of children, such as 25%. And patients with dengue do develop GIT symptoms such as abdominal pain, vomiting, and diarrhea. And if you do the initial lab test, would show lymphopenia, some degree of thrombocytopenia, elevated liver enzymes, and CRP may be elevated in dengue in some patients, especially those who go on to develop dengue hemorrhagic fever, but usually not more than 50. So when you look at these clinical features, and if you were not seeing the dengue here, I mean, they're very similar to the clinical features of COVID. So in countries where you have both dengue and COVID, you get there's a lot of issues with initial diagnosis, and I'll come to that later. Now, how does dengue manifest and what is the natural cause of dengue? So I just mentioned dengue starts with a rapid rise in temperature, and this high temperature phase is from day 1 to around day 3 to 4, and this coincides with the viremia. The patient has high fever and viremic, and as the viremia subsides, the temperature also subsides. But that is not good news for some patients. For those who develop dengue fever and who do not develop severe dengue in the form of dengue hemorrhagic fever, with the lowering of temperature, they directly go into the recovery phase, and that's it. But some patients who develop dengue hemorrhagic fever, with the lowering of the temperature, there is plasma leakage, and because of that, there is a rise in the hematocrit, and this coincides with the rapid drop in the platelet count. And this critical phase, where the fluid leakage happens, lasts for 24 to 48 hours, after which the hematocrit rises, lowers because of fluid reabsorption into the capillaries, and it coincides with the rise of platelets, and the patients go on to recovery. Now, what is the pathogenesis behind this? And this is, of course, when the mosquito initially bites infected mosquito, it injects dengue viral particles into the intradermal capillaries, and these dengue viruses infect monocytes, macrophages, mast cells, dendritic cells, keratinocytes, many types of immune cells. And this initial viral replication results in the production of massive amounts of cytokines, chemokines, and other inflammatory mediators. And in this, after this rapid virus multiplication and production of these inflammatory cytokines and other mediators, these act on the endothelium, causing endothelial dysfunction. And because of this endothelial dysfunction, there is fluid leakage, which coincides with the critical phase. And when the patient, and when there is reabsorption of fluid and the endothelial dysfunction subsides, the patient goes on to the recovery phase. Now, plasma leakage because of endothelial dysfunction is the hallmark of severe dengue. And a lot of complications that occur during dengue hemorrhagic fever can be explained by the plasma leakage. So for instance, because of the plasma leakage, there is accumulation of fluids in the pleural cavities and in the peritoneal cavities, causing pleural effusions and ascites. This leads to respiratory distress if they are very large. The plasma leakage results in hypotension because of reduction in blood pressure. Because reduction in blood pressure, there is poor organ perfusion, and this affects the liver, causing liver dysfunction, resulting in acute liver failure and hepatic encephalopathy. And poor organ perfusion of the kidney results in renal dysfunction. Because of this rapid lowering of the blood pressure, when it goes on without fluid replacement, that results in shock, and prolonged shock leads to cerebral hypoxia. And hypotension, when there is lowering of the blood pressure, the blood is shunted to important organs, and there is certain degree of intestinal and uterine mucosal ischemia, leading to gastrointestinal and vaginal bleeding. So plasma leakage is not the only reason of bleeding, but plasma leakage is an important cause of bleeding in dengue hemorrhagic fever. And some studies have shown that untreated dengue hemorrhagic fever is associated with a mortality of 20%. Now, the questions we have been interested in are what causes fluid leakage, and of course, why do some individuals only develop fluid leakage? Because the vast majority of individuals have asymptomatic infection, and the people who do show symptoms, the vast majority develop dengue fever, and it is only a minority, a smaller proportion, who develop severe dengue and go on to develop vascular leak and dengue hemorrhagic fever. And this is just shows what is meant by endothelial dysfunction. So this graph, this is actually a picture of endothelial cells in the presence of normal healthy serum. And you can see the endothelial gap junctions are intact and they is nicely adhered to each other. But here are the endothelial cells in the presence of a serum from patient with dengue shock syndrome. And as you can see, there is gross degree of endothelial dysfunction. So this is what happens in dengue hemorrhagic fever, resulting in plasma leakage. So we have been trying to find out what causes this endothelial dysfunction and whether we can find ways to treat it. Now, there have been several mediators implicated in vascular leak. I have already listed some and some of the things that we've been looking at. So we have been especially interested in inflammatory lipid mediators, and I'll just show a little bit of data on that. PAF, the phospholipases, secretory phospholipase, and cytoplasmic phospholipase, and the leukotrienes. And cytokines, of course, have shown to cause vascular leak in other models, IL-6, IL-1 beta, TNF-alpha, and these cytokines come from different sources. There have been quite a bit of work done on mast cells, and mast cell products such as VEGF, tryptase, kinase, and histamine have shown to cause vascular leak. And NS1 alone, which is a secretory protein of the virus, which circulates independent of the virus, has also shown to cause vascular leak by Eva Harris's group. And of course, we've been looking at NS1 antibodies and if those are associated with vascular leak. Now, what we've been especially interested in is that one approach to treat dengue is antivirus, but whether another approach would be to find drug targets that prevent this vascular leak. And so during our investigations, we found that platelet activating factor, or PAF, is important for soft vascular leak. So this is the pictures I showed earlier. And when you use a platelet activating factor receptor blocker, before adding the serum of the dengue, patients with dengue shock syndrome, there is a significant reduction in the endothelial dysfunction. So because of this data, we proceeded to do a preliminary study on the use of this drug called Ropetatine, which is antihistamine and also has a platelet activating factor receptor blocking effect. And so we did an initial randomized placebo-controlled trial. And in this trial, we found that people who were given Ropetatine had significantly less pleural effusions. The amount of leakage was less, and they were less likely to develop severe decrease of thrombocytopenia, and significantly inhibited or reduced the rise in the liver enzymes. And because of these initial preliminary results, we went on to do a subsequent study, a follow-up study, which was a double-blind, placebo-controlled randomized trial. And the main endpoint of that trial was the efficacy of Ropetatine to reduce the incidence of dengue hemorrhagic fever. And we had almost finished the trial, which just short of 19 patients when COVID happened. So we had to prematurely stop the trial, short of 19 patients. And just talking about the initial results of this trial, in the treatment arm, which consisted of 127 patients, the incidence of dengue hemorrhagic fever was 16.8, which is the placebo arm, which is the proportion of dengue hemorrhagic fever seen in patients receiving outpatient care in Sri Lanka. And in the Ropetatine arm, it was 9.8. So it did reduce the proportion of people developing fluid leakage, but of course we haven't completed the trial and we might just terminate it because there is no hope of continuing it. We have also been looking at other markers, especially because there have been publications, especially from Ashley St. John's group from Duke NUS Singapore, about the mast cells in dengue. So we looked at this mediator called leukotrienes. So leukotrienes, the LT4 of leukotriene is a very stable compound in urine. So we looked at LT4 levels. And as you can see, the levels were significantly higher in patients with dengue hemorrhagic fever compared to dengue fever early in illness and later in illness. And when you look at the kinetics of LT4 in urine in acute dengue, they more or less remain the same levels throughout in patients with dengue fever, but significantly increased in patients with dengue hemorrhagic fever. So we're very excited that we could use this as a biomarker because it's a urinary substance, and it would be good to have a urinary test to look at a biomarker. But unfortunately, what we saw is that there's a significant diurnal variation in the LT4 levels in patients with dengue fever and dengue hemorrhagic fever, and there's a several-fold difference in the morning versus afternoon, and by the way around in both dengue fever and dengue hemorrhagic fever. And we also saw, we did the viral loads of these individuals, and the viral loads also significantly changed in during morning and afternoon samples. So having looked at LT4, so one reason the reason we looked at LT4 was because there are already existing drugs to block leukotrienes, but another mediator we looked at is histamine, which is again a mast cell mediator, and of course there are antihistamines around which are widely used. Again, we saw that histamine level, urinary histamine levels were significantly higher in patients with dengue fever and dengue hemorrhagic fever compared to healthy individuals, although there were no difference between dengue fever and dengue hemorrhagic fever. So these studies have shown us that plasma leakage in dengue is the predominant cause of dengue hemorrhagic fever. And of course, apart from the mediators that I showed, PAF, leukotrienes and histamines, there are many other mediators that actually cause vascular leak, which have very conclusively shown to cause vascular leak. But PAF, LT4 and other mast cell products are important because there are existing drugs that actually block the activity of these mediators. So repurposing existing drugs should be explored because there are very cheap drugs out there which known safety profiles that can be rapidly repurposed. Now, coming to the final challenges we have now, dengue was bad enough, but now we have COVID. And some countries have both, which are the tropical and subtropical resource poor countries. We know that COVID was seen in Europe, America, and certain countries last year. But of course, the vaccination rates are very high in those countries now, and Europe and America are coming out of COVID. But the vaccination rates in tropical and subtropical areas are very low, and they're likely to be low until early next year. So until such time, the dengue and COVID, the clinical presentation is similar. But the problem in dengue is patients we know develop rapid fluid leakage during day 3 to 7 of illness. And DHF mortality is very high, around 20% according to some studies, if untreated. Therefore, intense monitoring is needed. So in Sri Lanka, the mortality rates of dengue is like 0.3%. So it is, we have managed to reduce this to 0.3%, but that is with intense monitoring and timely fluid management. So it is very important to closely monitor patients with dengue, whereas such close monitoring or hourly or 4-hourly monitoring is not done in the case of COVID patients. So if dengue patients are misdiagnosed as COVID patients, or there's a diagnostic dilemma, that will have devastating consequences for patients. And as I just mentioned, countries like Sri Lanka, India, and many South Asian and Southeast Asian countries are the current epicenter for COVID-19. And we also have dengue. So we have not so good times ahead as far as both infections are concerned. I would like to end by thanking all our collaborators. So I'm from the Center for Dengue Research at the University of Sri Java, and I would like to thank everybody, all my colleagues and my team members, my students working there. Professor Hammonk, our collaborator from University of Oxford, our collaborators from UK US Singapore, Ashley St. Jones and Ewan Ui, and our collaborators from the National Institute of Infectious Diseases. This is the hospital where we do our dengue studies, Dr. Ananda Vikrama Erangana Arangota, and Dr. Damayanti Dampiti. Thank you.
Thank you very, very much for that, Neelika. Fantastic presentation. We're already getting comments coming through the chat and the Q&A. Great presentation. Some kudos to you in terms of the clarity with which you've the clarity you brought to that this particular area of pathogenesis and the implications. In your last slide, just previous to your last slide, you were mentioning what happens if you get the diagnosis wrong because of the COVID co-infection, and really underlying the importance of your work and how it can then further inform not just the novel drug targets, but also the treatment strategies and the diagnostics themselves. So we'd like to say thank you very, very much for joining us all the way from Sri Lanka and highlighting those things.